final presentation in our symposium is by Professor T. Barankin, who will give us a lecture on the impact of war on children and youth of military families. Professor Barankin is an associate professor of the Psychiatry Department, Faculty of Medicine, University of Toronto, Canada, as well as a staff psychiatrist at the Hospital for Sick Children and the Canadian Association of Mental Health, academic educator, Center for Faculty Development. Thank you, Dr. Barankin.
Thank you for inviting me to present at this conference. And I'm very impressed with the previous presentations. This is supposed to be a lecture, but I'll try to do it in a shorter period of time, because some people might want to go for lunch. I will tell you that the learning objectives would be for us to become a little bit more familiar with military terminology and culture, as I had to become more familiar when I was invited to become a consultant in that area, to gain an appreciation of the impact of war on children and youth of military families, and to learn about a consultation process to primary care staff, which looks at unique aspects of mental health of military children and families. So military culture we need to know a little bit more about. The common military terminology, I won't spend a lot of time on that, but you know, people are posted when they are transferred to another military unit. Deployment is the assignment of military personnel to unaccompanied courses, training, and tasking. Being in theater means area where an operation mission is taking place. And there are peacekeeping missions, peacemaking missions, observations, and Canadian Special Operation Regiment. In most of the military experience deployment stress and some stress injury. The military lifestyle is very difficult. Most people live on the military bases, far away from the places they grew up, far away from places where there are grandparents and extended family for their children. This is a way of life. Very often they moved between different military bases, and it's also stressful to their partners. In some situations we had both husband and wife signed up for the military, and they have children who frequently have experienced dislocation and loss of parents. Military members are being deployed now more frequently, and often to very harsh environments, which in terms of climate differ from the climates of Canada, which everybody is asking me how cold it is there. I have to assure it's plus 15 right now, so it's not too bad. We have good summers and very cold winters. And different phases of pre-deployment, during deployment, and post-deployment, people experience different type of stress. So stage one is anticipation of loss and departure. So the whole family experiences that. Then there's detachment and withdrawal shortly before the military person is deployed. When people are arriving at their destination, they experience emotional disorganization. And then gradually, as the rules are introduced and the goals and tasks are explained, there's recovery and stabilization. Every so often they're allowed to visit family, not very often. So in anticipation to homecoming, this is another stage, is increased anxiety, fantasies about meeting their family and children. When a soldier returns, there's renegotiation of relationships, and then reintegration and stabilization. So there are a number of military community resources, but the important thing to remember is that the military person himself is under the Ministry of Defense, so they're very well supplied with physicians, psychologists, and others to help them with trauma and rehabilitation. Whereas the families are not covered by the Ministry of Defense, and therefore they're left to their own defenses. So what happened was there was a child and family center providing psychological services to children in the community, and suddenly, because of increasing deployment of the military and losses that the Canadians experience, there has been a flood of referrals to that small center, which was generally staffed by child and youth workers. There were only 2 social workers. There was half a he was now 1 day a week psychologist, and there was a psychologist in the French school. It's a very small community, but a very diverse community. There's public school board, there's Catholic school board, there's French school board, and there is French Catholic school board. So we needed to include the schools. I always work with the schools as well. Very briefly, I'll tell you about the case because that helps to illustrate what happens to these families. So I was invited to consult not only on cases, but also to consult and educate the staff which was working at this Pembroke Family Center. So this is one of the first family we saw. The father, who was deployed, was a medic. And they were told that, he's never going to be in military action, so, obviously he's totally safe. Mother is 36. Each child has a different father. Only the male child, age 3, his father was deceased. And this man who died, and I'll explain to you how he died, he adopted the other 2 children and played an important role in them. So the mother was not coping well with husband's death, and she was cleaning, she was keeping herself busy. The little one was regressing, and the grief has a very public nature in most military communities, but particularly in Canada. So they bring the soldier, they fly in first to Germany from Afghanistan. Canadian soldiers are deployed in a peace maintenance mission in Afghanistan, and most recently we started with 50, 100, now we deployed 500 soldiers. So there are deaths, there's mutilation, there's psychogenic trauma that these people experience. So when they arrived to Canada by plane, they arrived to a special facility in Trenton, approximately an hour and a half from Toronto. And they are taking in a very public procession with people standing basically on both sides of the highway, and it's called the Highway of Heroes, it was called. And then there is there's a public funeral, and then there's a private funeral. So the nature of grief is very public. And also we had to consult on how to approach the child with these news. They just didn't know, somebody, another military guy in full uniform would appear at the school bus where the child was stepping down from the school bus and approach and say your father was, the child was 6 years old. So that needed to be changed to be a little bit more sensitive. It's not done that way anymore. That was the role of the consultation as well. So every child, depending on their age in this family and in other families, had a different presentation. The teenage daughter was very resentful of her mother because mother became incapable of acting as a parent, and this 15-year-old had to become a parentified child and look after the younger children. There was a problem with bedwetting in the 8-year-old, and this child was highly anxious and sleeping with the mother all the time. And the little one was regressing. The father worked as a medic in Canadian military when the couple met. They did not expect father to die, and he was one of the first Canadian casualties in Afghanistan. They were basically giving out candies to Afghani children when an old man on a bicycle drove into this crowd and exploded. So this medic died, as well as the Afghani children to whom they were giving candies died as well. So this was one of the first Canadian deaths. What have they done? They have been developing groups for military widows, parenting support, education, respite, because some of these women were totally overwhelmed by suddenly becoming either widows or wives to a person who was severely mutilated by explosions. Family therapy was provided in this particular family, and we also did some individual work with a teenager, and we did some play therapy with the younger kids. So they were asking us a question for consultant. What else can they do? I'm not, this is the different, the Afghanistan is in the middle, obviously, here. I'm not going to present the second case just in the interest of the time, but fortunately the number of people who have died has increased a great deal. I was invited to become a consultant to that agency by the Hospital for Sick Children Telepsychiatry program. And that was due to the fact that I have experience in treating trauma for the Refugee Reception Center in Toronto. As well, I had defended a dissertation on Dr. Mary Constantieri. Where is she? She was one of the supervisors. This was many moons ago, on adaptation of Soviet immigrants Soviet refugees to Toronto. As well, I'm an educator, have been a director of continuing education, so I'm looking for effective modalities to teach stuff. And that facility was very important because they were severely understaffed. There was no child psychiatrist, there was no adult psychiatrist in that facility. As I said, there was a one-day psychologist, 2 social workers, and child and youth workers. So the consultation process was defined by Kaplan as a process of interaction between professionals. So there's a consultant and there's a consultee, a person to whom you do the consultation. And the consultant's help is needed to, because of their areas of competence and expertise, to help them with current work problems. So as a consultant, the role is to help clarify diagnostic formulation, to provide advice about treatment, and anticipation of future problems. Consultee can take your, accept your recommendations or not, or they could reject it. But this is my consultation team, so I want to acknowledge their contribution. And consultee was the Phoenix Center for Children and Families. Consultations come in different types. Client-centered consultation is more about a case. So, for example, this case that I presented, it would be presented to me, and they would say, well, this is where we are stuck. What else can we do for this family? Oh, this is not working. Remember, this is a small rural community where the military base is, and they do not have sufficient access to psychological help. The consultee-centered case consultation is what I was also doing, and that involves improving capacity of the consultee, increasing their knowledge and skills. So I would spend, let's say, 2 hours with them on a regular basis, every 2 weeks, once a month. It would start with a consultee-centered case consultation, or the administrative center. This is number 3, program-centered administrative consultation. First of all, we needed to create a team to whom I could consult. And initially, there were only a few people from this Pembroke Center. I said, no, I want schools on board, because these kids attend schools. Unless we could provide intervention and support at school, I don't think it will be comprehensive. So they brought in the school psychologist, they brought in a social worker from the school. So every month, they met as a team. That was the only place where they met. Otherwise, they were disconnected from the schools. And we also brought in a person from the adult services for the military guys who also, they were a little bit disconnected from child and family services. As well, I provided lectures, so I could, let's say they were interested in treatment and understanding of trauma. It was specifically trauma in military families. So I would start with a 20-minute presentation. We would discuss questions, then we would discuss a case. So trauma was very much asked about presentations. Divorce. Divorce is very common in these families after the deployment, after the person returns from the military. There has been an increase in divorce and the impact that has on children and family. Another area which is very dear to me, as my main interest is interest in prevention and risk reduction model, is the area of building resiliency, and I've done many presentations on that. I most recently published a book called Growing Up Resilient. So how children and families could grow resilient despite adversity that they experience. And it's very relevant to the military population as well. And before you start a consultation, you don't just start consulting. I don't know these people. You have to build a relationship, and you are doing it through television. So all of that was telepsychiatry, right? So I was doing it through television. So this, for those of you who have done telepsychiatry, it could be very rewarding, but it's also difficult. You know, the eye contact, seeing the group, how they see and perceive you, is very different. So I needed to know, first of all, what is it that they need from me? Because you see, adult education has to be learner-centered. It's not something, I want to tell you this. It's more, what do you want to know? And let me think how I can tell you that so that you could learn the best possible way and so that you could also make it very practical. So in the beginning, there was this needs assessment, what they need, establishing goals, what can I do and what I cannot do, and forming this team and gathering information about their own experience and about the base, how many soldiers are deployed, what kind of problems do they see, and what kind of current treatment efforts they have implemented, and what is it that we could do in the future. So the problem, as I mentioned, was that it was a very small center, and it's interesting that they began to advocate through newspapers. I have one of the newspapers with me, and demanding more services for children and families, and eventually they were able to receive 2 more social workers and a few more youth and child workers because the injuries and deaths were mounting, and this impact on affecting children and family was tremendous, and there were not enough people to meet their needs. So they approached the ministry, they approached the telepsychiatry program at the hospital for sick children, and these were their concerns. And so I did a needs assessment with them both verbally and send a questionnaire. So there was increase in mental referrals. Kids experienced anxiety, depression, acting out, withdrawal. In parents, there was death, loss, injury, and uncertainty about the future. Then there was the impact of media on sensitized kids. We know how media could negatively affect kids, but these kids have a father in the army. They look at the news and they hear somebody died somewhere, and they immediately think, how do they know it's not their father or mother? They often had issues at school, because at school there was mixed population. Some kids were kids of the military, and other kids said, what do you mean deployed? Where's your daddy? How come he's not at home? They didn't understand that. And the staff had low capacity and was transitional. So that's what we did, and there was an ecological model where it was coordinated, integrated, multidisciplinary effort. I've done an extensive literature review on what is available, and unfortunately, because we live in the age of war and conflict, there's a lot of literature now, or significant amount of literature coming. A lot of it is coming from the United States, and I'm talking solid studies, studies that have come from Yugoslavia as a result of war in Yugoslavia, and a number of studies by psychologists in Israel. So these are the 3 clusters of work that is available in the literature, where you could learn a little bit more about what children, families, widows, and the soldier who is affected by physical or emotional trauma. So I use the risk reduction model, which implies early identification, treatment, decrease of pathogenic factors, increase of resiliency, and increase of protective factors. So we did it through case discussion, education, and we have began to implement questionnaires with that staff, because they have to collect it. We are not there, right? On what intake information we need, what type of diagnostic questionnaires we would like them to apply to children. And we looked at the existing services, and we made sure that at every stage of pre-deployment, deployment, and post-deployment, there are different types of interventions available to children and to their families. Specifics of the war situation for Canada is that it's the first military action since Korea in 1953. And there's no front line. War is all over. It's not like the enemy is here and you are there. You know, the modern war is all over the place. It's 24/7. And you always see it on TV. You know, by the time the news of the war came, you know, in 1945 or in 1953, it took weeks. Now you see it within an hour, you see what happened in another country. And many of our soldiers have limited family support because they're not located where their families are. So these are some of the things that we dealt with, that reviewed and shared literature with them, issues of countertransference in the therapists, because every therapist has feelings about seeing children and families impacted by the war, and we need to be aware of that. My father was in World War II. I have feelings about the war and children, the war children from that area. But we have many social workers whose husbands are in the military currently. They have a particular attitude counter-transference. You have to remember that. And we dealt with stages of grieving, shock, pain, protest, acceptance. That's another lecture. And what is the best way to give explanation, and massive relaxation strategies such as mindfulness meditation, the art of living meditation, to help children to decrease their hyperarousal process, because many of them are anxious, acting out. And identifying the children at risk. Not all children respond the same way. Kids with pre-existing anxiety, with pre-existing problems, react stronger. The family's boundaries and parentification important, because the older kids step into the role of a father when the father is away. Fears, anxiety were addressed through cognitive behavior therapy, and we also dealt with the impact of media. We have introduced trauma groups, bereavement groups, as well as guided the process of individual and family assessment. And, as I said, unfortunately, a lot of families coping with death of a parent. A lot of literature came from 9/11. And unfortunately, I can't show you the puppet play, although I have a newspaper, was that they developed a puppet play that now is actually done across Canada, where kids learn a little bit about, what happens in the military, and it demystifies it a little bit. And teaching kids stress management skills, such as deep breathing, imagery, dealing with the media, and groups that prepare children before the parents are deployed, as well as different education and resources and monthly staff meetings. So this is the DVD didn't work out. And so the consultant's work addresses the needs of the consultee via knowledge sharing, recommendation of case management, dealing with death, loss, trauma, acting out, as well as supporting a cohesive multidisciplinary team of professionals from different agencies. And transference issues were very important. And thank you very much for your patience. Just to conclude, there has been significant mental health impact of deployment and trauma on children and families. They demonstrate significant anxiety, sleep disturbance, sense of uncertainty, loss, grief, various trauma, parentification and family fragmentation and role strain. The telepsychiatry consultation process has been addressing the needs of the treatment team, and knowledge and skill dissemination, validation and support, and creating cohesive community of care have been highly valued by the consultees. We receive feedback at the end of the year. We have a discussion, what they liked, what they need for the future, what has been most helpful. And building cohesive assessments and interventions is one of our kind of biggest accomplishments, as well as focusing on improving services and outcome and the families affected by the deployment. Thank you very much.